The proximal tubule reabsorbs most nutrients and water. The loop of Henle concentrates and dilutes urine. The distal tubule fine-tunes sodium and calcium. And finally, the collecting duct, where aldosterone and ADH make the final adjustments. Thiazides act on the distal tubule. In this 3-minute video, you'll master the mechanism, the side effects, and the dangerous drug interactions of thiazide diuretics. Thiazides block the sodium chloride cotransporter in the distal tubule. This stops sodium and water reabsorption and produces mild diuresis. They are not as strong as loop diuretics, but they also dilate peripheral vessels. That's why they are the first-line drugs for hypertension. They are especially effective in the elderly and in African American patients because these groups often have low renin hypertension, where RAAS inhibitors like ACE or ARBs work poorly. Let's quickly review the distal tubule. Sodium and chloride are reabsorbed together from the urine, then sodium is pumped into the blood by the sodium-potassium ADPase. Here's the key point. When intracellular sodium falls, the sodium-calcium exchanger NCX1 becomes more active, brings sodium into the cell and pushes calcium out into the blood. Thiazides block the sodium chloride cotransporter in the distal tubule. Now the side effects. Why do thiazides cause hypokalemia? When sodium reabsorption is blocked by thiazides, more sodium reaches the collecting duct, sodium is reabsorbed in exchange for potassium, and potassium is lost. Hypercalcemia can be both a side effect and a therapeutic effect. Because the sodium-calcium exchanger is more active, calcium goes back into the blood. This is the opposite of loop diuretics. Third, hyperuricemia. In the proximal tubule, thiazides compete with uric acid for the organic anion transporters, so uric acid secretion falls and gout risk rises. Fourth, impaired glucose tolerance. Low potassium reduces insulin release from pancreatic beta cells, leading to hyperglycemia and insulin resistance. Fifth, lipid abnormalities. Volume contraction activates the sympathetic system and RAAS, which increase lipolysis. More free fatty acids reach the liver, where they are converted into triglycerides and VLDL. And finally, photosensitivity. Because thiazides contain a sulfa group, UV light generates reactive oxygen species, causing skin damages. Now, the dangerous combinations. First, desmopressin. Stimulates V2 receptors in the collecting duct, inserts aquaporin 2, and reabsorbs water only. Together with thiazides, sodium goes down and water goes up. The result is severe dilutional hyponatremia. Second, digoxin. Normally, cardiac myocytes pump sodium out, keeping intracellular sodium low. This low sodium serves as the driving force. Sodium enters and calcium is pushed out. Digoxin blocks the sodium-potassium ADPase, so sodium builds up inside. The driving force is lost, calcium cannot leave, and it accumulates in the cell. More intracellular calcium means stronger cardiac contraction. With thiazide-induced hypokalemia, digoxin blocks the sodium-potassium ADPase even more strongly. Sodium rises inside the cell, the sodium-calcium exchanger slows down, and calcium overloads the cell. Contractility increases, but the price is a dangerous risk of fatal arrhythmias. Thanks so much for watching all the way to the end today. On this channel, I do my best to make medicine easy to understand and maybe even a little fun. If you subscribe or give this video a like, it really means a lot and keeps me motivated. See you in the next video.
For quick, powerful reviews, this is the only channel. Don't forget to subscribe.